So it is one of the category of glaucoma suspect. So as you know, the glaucoma is group of disease that had a specific at the end specific pattern of visual field dysfunction with sometime risk factors, and all of these lead to a progressive optic neuropathy, and usually classified primary based on what they have elevated intraocular pressure without any secondary cause. And this is usually, if you want to label patient as glaucoma suspect, he need to have the same criteria for primary open angle glaucoma, except that he already diagnosed with glaucoma. As you know, the primary open angle glaucoma, you have to have high pressure in most of the patient. If the pressure is still within normal, you can label the patient as normal tension glaucoma, but we have another um, entity, we call it the ocular hypertension. If the pressure is high, but still there is no obvious structural or functional damage to the optic nerve. So in most of the literature, usually they describe the risk factors for glaucoma without specifying is this a risk factor for developing the disease or it is for the progression. So some risk factor can be identified by the patient history, like age, race, family history, and the other you can it can be based on clinical exam and investigation that you can do to the patient. So the this is the clinical finding characteristic of primary open angle glaucoma suspect based on the preferred pattern practice in the American Academy. So usually an individual with open anterior chamber angle, you have to have one or both eyes that they have elevated intraocular pressure with normal appearance of optic disc, visual field, and nerve fiber layer. This is the definition of ocular hypertension. Or an appearance of optic nerve head or retinal nerve fiber layer that's suspicious for glomatous damage. So with this definition, usually you exclude angle closure, you exclude pseudo-exfoliative, and you exclude the pigment and the other open angle glaucoma. The third thing is the visual field that usually consistent with the glaucoma damage, but usually in the absence of clinical signs of another optic neuropathy. So this is the usually risk factors that mostly associated with primary open angle glaucoma and it is progression. So the most important four that based on multiple studies: optic nerve head alteration, high intraocular pressure, old age, African origin, and the confirmed family history. This is moderate risk. Diabetic and hypertensive patient. This is modest risk. So the most important if you have patient with suspect, you move to the optic nerve. So the usually is the most significant risk factor and diagnostic signs that based on the define the glaucoma patient as having the disease. So, but the issue sometimes there is an late or limitation of the early detection of the changes in the optic nerve, and this is one of the important things that other tests can cover. Optic disc hemorrhage also one of the risk factor and usually associated with faster rate of glaucoma progression, or this is mainly in the collaborative normal tension glaucoma study, and usually it can convert or that have higher risk, sixfold increase in developing primary open angle glaucoma. This is in ocular hypertension study patient. Intraocular pressure. This is usually one of the strongest risk factor or modifiable risk factor for glaucoma, and sometimes it is the cause of the disease. So usually, high IOP level are associated with glaucoma progression. Sometime variability in diurnal IOP and large IOP differences between the fellow's eyes usually found to be more common in primary open angle glaucoma than normal individual. So in early manifest glaucoma trial, the median follow-up of 8 years confirmed that aerial find that elevated IOP is the strongest or one of the strong factor for glaucoma progression, with a ratio around increase by 11% per increase 1 millimeter mercury of intraocular pressure. And most of other studies, usually IOP dependent variable associated with visual field progression. Usually they found the IOP fluctuation, IOP peak, was the most common risk factor rather than the high IOP itself. Age is the this is they found it in okay, hypertension study is one of the risk factor that if you see a patient with high pressure and still the optic disc and visual field within normal, if the age increase by 10 years, this is usually will give more than 10%. In other studies that most of them, if you keep IOP aside, the strongest independent risk factor, they found it is the age. With age above 60, they have 7 times more likely to develop glaucoma than those age less than 40. The black race, usually primary open angle glaucoma, was found to be 4 to 6 times more frequent among individuals with African American origin compared to white individual. On average, primary open angle glaucoma usually they start earlier in American African. This is one reason, and the other reason they found in African American they have lower central corneal thickness. So this is one of the other risk factors. In Los Angeles Latino, I study also 4 years incidence of primary open angle glaucoma in Latino was higher than in non-Hispanic white, but lower than African American. So African American, then Latino, then white individuals. So this is usually family history of glaucoma increase the risk of individual developing the disease. Although the exact inheritance pattern is still unknown, but as you know, open angle glaucoma is multifactorial. The glaucoma inheritance study compared the distribution of patients with their places, confirmed familial primary open angle glaucoma and those with sporadic. And they found the familial group usually they have the disease at younger age and more severe disease than the patient with the sporadic group. Usually, this finding support the value of screening, especially if there is family members that they have the disease. So the lifetime absolute risk of glaucoma at the age of 80 years was found to be almost 10 times higher for individual having relative with the glaucoma than for patient with negative family history. So this is usually as a multivariant with age and family history. Um, Barbados family study of open-angle glaucoma investigated the inheritance of primary open-angle glaucoma among families of black race and also found family history to be a major risk factor for glaucoma confirmed by direct examination of the relative. But still, family history alone cannot be accounted for. The observed prevalence of the disease suggests that non-genetic factor may play a role in the developing the primary open-angle glaucoma. Diabetic patient, a several study investigated the possible relation between the primary open-angle glaucoma and diabetes, and the prevalence was higher in diabetic individual compared to non-diabetic. In Bloomington, I study glaucoma prevalence and ocular hypertension were more common in people with diabetes. Other prospective study of glaucoma reported a greater likelihood of progression in patients with diabetes, especially type 2. In Baltimore Eye survey, the association also between the glaucoma and diabetic was found to be weak. On the other hand, unexpected finding from the ocular hypertension study that suggests that subjects with self-reporting diabetes usually have lower risk of progression to primary open-angle glaucoma. So still, the diabetic patient or diabetes is controversial as a risk factor for to convert from glaucoma suspect to a primary open-angle glaucoma. Hypertension, a patient with hypertension usually in one of the study they called Blue Mountain, also the same, they investigated the hypertension and diabetes with glaucoma. They were more likely to have systemic hypertension than the participant without, 65% versus 45. The positive association between the elevated pressure and the primary open-angle glaucoma was reported, but larger population-based study like Framingham and Baltimore failed to confirm the association. Usually, systolic and diastolic blood pressure showed a modest positive association with primary open-angle glaucoma, but usually if you adjust the age for the pressure, individual usually with systolic blood pressure more than 130 had a higher prevalence of primary open-angle glaucoma. Low perfusion pressure, which is blood pressure minus the intraocular pressure, usually strongly associated with an increased prevalence of open-angle glaucoma with six-fold for those in the lowest category of perfusion pressure. There is other risk factors like myopia, pseudoexfoliative migraine, caliber of retinal vasculature have been reported, but with weak association. So as we said, the definition of ocular hypertension is high pressure, normal disc, and normal visual field, normal OCT, and usually those patients, 1 to 2% of the ocular patient develop primary open-angle glaucoma. This is annually, and usually sometime you bring the patient to the clinic even with lower pressure. You find the patient in the next visit they have higher pressure, and then you diagnose the patient. So why some patient with ocular hypertension develop glaucoma and why other not? Because usually the different clinical response to intraocular pressure is are likely to due to intrinsic factors like that different from patient to patient. Usually the neuroprotective factors, microstructural anatomy of the optic nerve, immune response, and the difference in the optic nerve blood flow. All this can make some patient go from glaucoma suspect to primary open-angle glaucoma. So one of the largest studies, the ocular hypertension treatment study. So the objective to determine the safety and efficacy of topical ocular hypotensive medication in delaying or preventing the onset of primary open-angle glaucoma. And the method usually uh, in the main study and the study then after this one, they have a total of almost 1,600 with no evidence for glaucoma, all the age from 40 to 80, IOP between 24 or let's say 21 to 23 in one eye, and the other eye, the right eye should be higher than the other one. Usually they randomize the patient to observation or to receive available topical hypotensive medication. The main goal for the medication group is to decrease the intraocular pressure by 20% or more, and to reach an IOP of 24 or less. So this is the main goal for in the treatment group. So during the course of the study, the main reduction in IOP in medication group was 22.5 and almost 9.9, and the IOP declined by 4% in the observational group. At 60 months, the cumulative probability of developing primary open-angle glaucoma was 4.4 in medication group and 9.5 in the observational group. So the conclusion of the study is that topical ocular hypotensive medication was effective in delaying or preventing the onset of primary open-angle glaucoma in individuals with elevated intraocular pressure. The other phase of the study to describe baseline demographic and clinical factor that predict which participant in the study develop primary open-angle glaucoma. So the baseline demographic and clinical data were collected before the randomization, except for corneal thickness, which was taken during the study. Then they conclude at the end that in both multivariate and univariate, that baseline age, vertical cup disc ratio, pattern standard deviation, intraocular pressure, and central corneal thickness were good predictor for the onset of primary open-angle glaucoma. The central corneal thickness was found to be powerful predictor for developing the disease. So if the patient had 555 or less, so this is they have threefold greater risk of having progression from glaucoma suspect to a glaucoma. The other risk factors they found only on univariant, the race, African American, male sex, and the patient who's having heart disease. So most of those risk factor was excluded, and this is will come in the other study. So baseline factors that were not associated with the risk of developing open-angle glaucoma in patients with high pressure in both univariate and multivariate, a family history, mean deviation, correct pattern standard deviation, myopic patient, migraine, cerebrovascular accident, high blood pressure or low blood pressure, and use of oral adrenergic antagonist or oral calcium channel blocker. So if you can see here, this is central corneal thickness and baseline IUB. If you see if the patient had corneal thickness less than 555, and this is the risk of conversion to glaucoma is more, and it goes more and more with high pressure. So this is corneal thickness with high pressure, and this is corneal thickness with vertical cup disc ratio. So if you can see here, it is almost 21%. If it is less than 550 and the cup disc ratio more than 0.45. The other major study is the European Glaucoma Prevention Study. So the objective of this study is to evaluate the efficacy and of reduction of intraocular pressure by dorzolamide in preventing or delaying primary open-angle glaucoma in patients affected by ocular hypertension. It is randomized, double-masked, controlled clinical trials. More than 1,081 patients, the age from 30 to 80. Inclusion criteria IOB 22 to 29, and the normal and two normal reliable visual field, normal optic disc. This is usually by clinical exam, and the intervention was patient were randomized to treatment with dorzolamide or placebo. And the main outcome measured the efficacy endpoint were visual field, optic disc changes, or both. Visual field changes during the follow-up had to be confirmed by two positive tests, and optic disc changes also examined by two independent observers, and they agree on this evaluation. The conclusion of this study, the dorzolamide reduced the pressure by 15 to 22% over 5 years, but they failed to detect statistically significant differences between medical therapy and placebo in reducing the incidence of primary open-angle glaucoma among large population of ocular hypertension patient at moderate risk for developing primary open-angle glaucoma, because the placebo does the same lowering process. So what they conclude at the end, the risk factor, baseline age, vertical and horizontal cup disc ratio, pattern standard deviation, lower central corneal thickness, and baseline cup disc asymmetry. Pseudoexfoliative cardiovascular disease and high IUB, this is they found it only in univariate factors. So if we take both study, so what is the usually they found in both trial as a risk factor? First is the old age, thinner central corneal thickness, increased cup disc ratio, and greater pattern standard deviation. This is in all in both study. In ocular hypertension, high IOB one of the risk factors, and the baseline cup disc asymmetry is an European glaucoma prevention study. So at the end, if you have a patient, you don't know, you will start the treatment or you want to wait. So in this situation, better to move to what we call risk calculation. So Mansberg, they and Medros et al. They develop a pointing system for baseline protective factor to help estimate 5 years progression of glaucoma. And this point system using the data from both study to estimate that risk. So what is the benefit for the patient? Usually, uh, those patients will be more compliant or adherent to the therapy if you tell him that risk. And usually, clinician and individual estimate developing glaucoma in 5 years. So you give the follow-up based on that risk calculation. So there is, they put specific the point based on the both studies. Um, uh, they put first age, intraocular pressure, corneal thickness, and button sand deviation, vertical cup to disc ratio, and diabetic as a protective in ocular hypertension treatment study. Then they after that they remove diabetic from the point, and then they start to have only the intraocular pressure, age, corneal thickness, beta sand deviation, and the vertical cup to disc ratio. So as you can see here, this is the point system. The age is by year. So once you increase by 10, it will increase by the point by 1. And usually it is 5% between each 10 years. The intraocular pressure is the same. If you can see the corneal thickness, if it is less than 525, patient will take 4 points. Vertical cup disc ratio, mean beta sand deviation, then you calculate the point. So if it is more than 12, this is patient will have 33% of having risk during the 5 years to have um, primary open angle glaucoma. If it is less than 4, the risk is if it is from 0 to 6, the risk is less than 4%. So if you have the point, then at which percentage you will treat. So let's say if you have 10%, if you have 15 or 20 or less than 4, most of the studies said that if it is 10%, you start the treatment, and this is usually based on patient, other factors also. The follow-up of the patient, he's going to follow up with you frequently, or he will be like the gap between the two follow-up would very high or no. So this is the risk factor and the relative risk for increased glaucoma per age. So the age every 10 years will increase by 22%. And the IOP, each 1 millimeter, it will increase the risk by 10%. Corneal thickness decreased by 40, it will give you 71%. The vertical and horizontal cup disc ratio, each 0.1 will increase around 30%, and the pattern sand deviation 0.2, it will increase the chance by 27%. So how use this pointing system? Required the following information: the age of the patient, vertical cup disc ratio, IOP, 3 measurement per eye, measuring using Goldman ablation tonometer. Then you need to have also central corneal thickness using an ultrasound pachymetry, 3 measurement per eye. Then you take the average, and the pattern sand deviation using any of the following 2 measurements per eye: Humphrey full threshold 30 or 24-2, or CT standard 32 or 24-2, or loss variance from Octopus 32-2. There is 2 types. of point, how you calculate the continuous method based on the actual data of the patient and the simplified point system. For the continuous method, you will enter the actual data of the for the patient, age and eye measurement. For the pointing system, it will give you a range that you can put the numbers, and then the result will give you. But most of if you put the two, most of the result will be similar, but not identical to each other. So this is one of the website that can give you the risk. Just you put the all the information, then you calculate, and it will give you the number by percentage. And this is the one in the website for ocular hypertension treatment study. This is the continuous method. So this is you need to put the age of the patient and the all the measurement you did for the patient. Then you and this is usually will be more accurate than the point system. So this one is the continuous one, and this is the point point one. This is both of them. You will find it in the ocular hypertension treatment study website. Then you estimate, then it will give you immediately the risk. And this is the a link for the website. So some factors described as predictive in previous studies either did not add an explanatory power to the both study or were not assessed in this study at all. This include myopic patient, diabetes, race, cardiovascular disease, family history of glaucoma, and exfoliation syndrome and pigmentary glaucoma. So the prediction method present here, usually it's take all the data from both study, from the ocular hypertension and from the European glaucoma prevention study. And this is usually you cannot apply all this data to your patient. Sometimes there is a variable measure that you need to change during the follow-up. So the decision to treat the patient with ocular hypertension is not an easy, so we need to take in consideration the patient life expectancy, patient compliance, and patient education and side effect of the ocular medication. So this is the highlighted finding and recommendation for care by preferred pattern practice. So the usually, as we said, the suspect established by presence of high intraocular pressure, okay, or change in the optic nerve, retinal nerve layer, and or visual field. All this in one or both eyes. So if you find the established risk factor is old age, African race or Latino, elevated intraocular pressure, family history of glaucoma, low ocular perfusion pressure, type 2 diabetes, myopic patient, and thin central cornea. This is collected from all the study, not only these two studies. So the decision to treat is depend on the level of intraocular pressure and other associated risk factors or evidence of change of the optic nerve, retinal nerve layer, or visual field indicating that the patient developing glaucoma. In the ocular hypertension treatment study, more than 90% of patients with untreated ocular hypertension did not progress to glaucoma over 5 years, but treatment to lower IUP reduced the risk of developing open-angle glaucoma from 9.5 to 4.5%. Usually, the reasonable target of intraocular pressure reduction in primary open-angle glaucoma suspect that you decide to treat is 20% of the baseline intraocular pressure. And usually you need to test those patients and evaluate and monitor the patient that you do not start the medication. You have to do barometry and tonometry every visit, perimetry and careful examination of the optic disc, ocular imaging, and the most important is to have a follow-up to compare is there any change. As you know, some patients they refuse to start the treatment until they develop some changes. Any questions? Sorry? When to stop? Okay. So most likely if you do 3 visits, 6 months apart, this is enough to discharge the patient. But you take in consideration that other risk factor is not there. So if the patient had family history, and not only family history, if the let's say one of the parents lost the vision from glaucoma, so this is a different story. Not even a family history. This is a loss of vision from glaucoma. So this is usually you need to extend the follow-up for up to 3 years. You mean? I don't understand the question. You mean why some of them develop, why not? Or does the biomechanical properties of the growth affect the decision of treatment, or that in recent studies that prove that the biomechanical IUD for those patients different than the explanation? Yeah, I understand. The most important two study is the ocular hypertension treatment and the European prevention glaucoma study. The other usually small size or the loss of the follow-up and the most of the risk factor they found it usually in the same these two study with the difference that it is univariant or multivariant.